Okay, we'd like to go ahead and get started with the next part of our hearing. So we're going to invite up our second panel, Anthony Wright, Peter Finn, and John Arensmeyer. Arensmeyer, excuse me. Sorry. And do you need slides on? Oh, we'll be right there. Okay. Whatever you're ready. So we'll go ahead and get started here. Our first speakers this afternoon: Anthony Wright, Executive Director of Health Access California; Betsy Estudillo, Senior Policy Manager, Health and Benefits, California Immigrant Policy Center; Peter Finn, the Treasurer, Principal Officer of Teamsters Local 856, Sara, no stranger to us here on the committee, Policy Coordinator for the California Labor Federation, and John Arensmeyer, Founder and CEO of the Small Business Majority. So, Mr. Wright, you have the floor.
Thank you. Let me try again. Great. Again, thank you, Chairman Wood, Chairman Arambula. I'm really pleased to be here. My name is Anthony Wright. I'm the Executive Director of Health Access California. Health Access is the statewide healthcare consumer advocacy coalition working for the goal of quality, affordable healthcare for all Californians. For 30 years, we've worked both on the vision of a universal healthcare system in California, and also on the legislative and budget battles of the moment. In the Capitol, as you know, many of my colleagues working to represent the patients and the public, sometimes as a counterpoint to insurers or doctors or drug companies or hospitals, to try to make sure that we have a better healthcare system. And we've always tried to balance that with putting forward the vision of how do we get to a system that is truly universal, both in care and in coverage, and protecting people so that we don't have people who are uninsured, who live sicker, who die younger, and who are one emergency away from financial ruin. We care about that people have access to care, but also that they are financially protected from medical bankruptcy or significant medical bills. We've appreciated working with this legislature in the last few years on a range of issues, whether it's been on the leadership that the folks in this committee have worked on to ban the practice of surprise medical bills, whether to address high prescription drug costs, whether to work on timely access to care, on unfair out-of-pocket costs, and we hope that we can continue to make progress, and we're excited about this new conversation about taking additional steps forward. To talk about where we just to create a little bit of baseline of where we are, obviously there's been a lot of progress that we've made under the Affordable Care Act, and especially because of the work that this committee has done, not just to implement, but to improve upon the Affordable Care Act. As a result of that work to implement and improve, millions of Californians have new consumer protections, new financial assistance with regard to getting the care that they need. 4 million Californians have new coverage as a result of that, and we've seen the biggest drop of the uninsured rate of all 50 states. That's something to be, we were at as much as 20% uninsured just a few years ago. Now the CDC has us at below 7%. We've done that because we've taken proactive actions, not just to be satisfied with the federal law, but to go forward, to have for example, an exchange that negotiates for the best possible price, to standardize benefits, to provide ways to get people quickly and easily into coverage, to expand coverage to new populations as well. And so The question I think that this committee is grappling with is if we can prevent the attacks on our healthcare system that we're seeing through ACA repeal and stop Medicaid cuts, how can we actually go forward? Just a moment about those attacks. That the proposals that we faced last year in Congress were significant. It's hard to overstate how much devastation they would have wreaked on our healthcare system, how much they would have handcuffed our ability to recover or even take steps forward. They proposed massive cuts to our healthcare system, cutting and capping the Medicaid program, leaving millions and millions more uninsured. Just 4 million more from getting rid of the Medicaid expansion, millions more if the proposal also undid some of the financial assistance in covered California or undid other provisions of the proposals, and undo some of the key patient protections that were proposed. The threat very much does continue. We want to be clear. The budget resolution that this Congress passed last year outlined actually Medicaid cuts that were twice as severe as the ACA repeal bill. You can see that, again, because of the cap that is being proposed at the federal level by some of these proposals, that over the course of 10 years, you would have a Medi-Cal program that would actually be providing half as much dollars to states. That is a significant amount of money of tens of billions of dollars. That is money that we need to cover this population, which now is almost 14 million Californians, a third of the state, half of all children, 2/3 of all nursing home residents. And this is, and so it's important to recognize that if this happened, this would be less money to even maintain our existing system or to fund any other system, whether it be single payer or any other system. So our first goal and our first focus of last year was to try to fight back against this proposal, and we need to have continued vigilance with regard to what is being discussed in D.C. If we can have the framework and the financing of the Affordable Care Act intact, however, there are things California can do to resist some of the administrative attacks that we've seen in on our healthcare system by the federal government. We've outlined at least 6 or 7 different ways where the Trump administration has sought to undermine our markets, destabilize our healthcare system, and undo the ACA and other key healthcare protections and provisions, and how California in each of those cases has resisted that. They defund the cost-sharing reductions in covered California. We found a workaround to claim those dollars from premium subsidies. They cut marketing by 90%. We increased our marketing so that people can get enrolled. And today, we actually have new numbers from covered California that suggest that enrollment actually went up by 3% despite all the federal uncertainty and issues. And so over 400,000 new people signing up for coverage in the last open enrollment. They sought to cut the open enrollment period by 3 months. From 3 months to 6 weeks, we maintained that 3-month open enrollment period and do so into the future with a bill by Chairman Wood. We worked to make sure that as insurers were exiting, that consumers continue to get continuity of care, and to the extent that they sought to undermine contraceptive coverage, we actually had pre-existing laws in place to try to at least make sure California regulated plan had that protection. But there is more to do to prevent the results of some of these attacks on our healthcare system, to make sure that people are not experiencing the premium spikes and the projections of increased in terms of more uninsured, more underinsured, more junk coverage, et cetera. So one of the things that the Trump administration do is to try to promote junk or substandard coverage that does not meet the standards of the ACA, often called association health plans, or also short-term insurance. We're looking closely at those association health plan regulations that are being proposed, and on short-term insurance, we're proud to be working on a bill with Senator Hernandez on banning that outright, so that we do not have substandard coverage that leaves people in the lurch when they do sign up for it, but also destabilizes the overall system. We're also looking at, to the extent the Trump administration is trying to lower the medical loss ratio, the amount of money that insurers have to provide to patient care rather than to administration and profits. They want to lower that amount through regulation. We believe California should look closely at actually raising that amount, making sure that we're getting more dollars that go to patient care rather than those other administrative expenses. And with regard to broader market stabilization, we do believe that in the absence of an individual mandate, we do need other efforts to try to stabilize our market. Especially, we think that actually it's the subsidies rather than the penalty that are the main driver of enrollment, and so a package on greater affordability would help in that regard of making sure that people continue to be covered. If that was partially funded by a more progressive individual contribution, that would be appropriate to encourage enrollment so that, again, we don't have the issue of increased premium spikes and more people uninsured. The CBO suggested that premiums will go up 10% as a result of some of the Trump sabotage that we've been seeing, and 1.7 million Californians would lose coverage. That's a UC Berkeley figure based on the CBO number. We want to prevent that from happening so we don't have any of the backsliding. And of course, we need ongoing vigilance with regard to this. But that's about just staying in the same place, and that's not what California wants to do. California has a long and important tradition of trying to move forward with health reforms to try to make sure that all Californians have access to the care that they need. This is a bipartisan tradition dating back to Governor Earl Warren. It is something, and we have traditionally over many years, certainly the 30 years of my organization, the 17 years that I've been in this position doing this work, we've certainly seen a range of different proposals work together. And I do believe that all of these efforts can and should be complementary to get to this goal. The question is, some of these proposals have always been on different tracks and different timetables, and I think that we are looking at one of those times again. And so I want to talk a little bit about that. And obviously, the goal that my organization has supported since its founding of a universal single-payer Medicare for all system is something that we strongly advocate full-throatedly. That it is we believe that a single-payer system, well-designed, this is not an ideological issue. This is about how do we get to these goals. A well-designed system is a way to get to the goal of universality, of having a publicly and progressively financed healthcare system, a system that is more cost-effective, a system that has comprehensive coverage, that is simpler and more efficient, and that is focused on preventions rather than profits. This is a system that we should continue to try to work to. We recognize, however, that this system does have its obstacles, as do most health care reforms. That there are a variety of obstacles to any type of health reform. I have some of the scars on my back to show for it, and it is it's having to figure out a lot of different. Get through a lot of different obstacles at once. It's almost like threading multiple needles at once. There's the political forces of industry and ideological oppositions. There's trying to get public acceptance, especially if something if you have to replace the coverage that people are used to with something different, even if it's going to be better. If it's the policy issues and trade-offs, including financing, and the process issues of just getting through the various hurdles, whether it be on the ballot in a legislature or otherwise. I think this committee has, been had a very useful several hearings that have gone into the details of these policy issues, and I think raised a lot of the right issues and the right questions. I think that these are resolvable issues, but they do take time and work to resolve. So these are not to say that these obstacles say you can't do it. That's certainly not what I think anybody should take away from any of those presentations, but we need to be clear-eyed about how we are going to address those issues in order to move forward. The one issue that does loom large in my mind is the one for need for federal approval, that if you're going to claim, in the case of a single-payer system, $200 billion or so from the federal government. How do you do that through Medicaid, through Medicare, through these other systems is a real challenge, even with a friendly federal partner. And obviously, that's not how I would characterize the current administration. It is an issue that I raised just because even if you were to submit a proposal, I mean, even the experience that we have in the last year, we have 1332 waivers that were submitted by states like Minnesota and New York, where the proposal was submitted and the federal administration says, if you want that waiver for this relatively modest issue of reinsurance or something like that, we're going to take that money by defunding another part of your healthcare system as a result. We now have in the Medicaid situation a situation where Indiana and other states have now submitted waivers to introduce work requirements and lockouts and other provisions in their Medicaid program. We can only imagine whether it's on immigration or reproductive rights or 5 other issues, what the federal administration in this current environment would require for the unprecedented permissions that we would be asking for in this proposal. So we think that we want to continue to advocate, to organize, and develop the goal of a single-payer Medicare for all type healthcare system, and we should take steps in the meantime while that do not require federal approval. What can we do? What can we do in the next year under Governor Brown, in the next 2 years under a new governor, where we can actually make progress on the goals of addressing issues of cost and quality and access and equity, while also not running into the brick wall of federal approval, and also while continuing to do the organizing, the policy development, the other work on additional broader reforms. And so that's what I want to talk about today. Just to be clear, California can't wait. People need continued help now. As much progress as we've made, there's more work to do, but and we don't want to wait for federal approvals. We can take concrete, actionable steps in this year and the next couple of years, while also then working toward a broader vision and a broader goal. And so, that's what I want to talk about today is these complementary efforts to move forward. And we think that some of these goals are to get to better universality and affordability. We can expand coverage expand coverage and public programs to cover all, regardless of immigration status, so that nobody is excluded to immigration status. We can extend affordability in covered California so that no one has to spend more than a percentage of their income on premium, and reduce premiums and cost sharing so that it's greater affordability. We can make real progress on issues of cost, dealing with healthcare prices, dealing with unjustified medical bills, making sure that people are not left at the whims of private insurers and in a bare county without any coverage options. So that's what we want to talk about here. You've seen this slide before earlier by one of my colleagues, our academic colleagues at UC Berkeley, suggesting who is left remaining uninsured. We've gotten it under 3 million, but there's clearly more to do. Clearly, you see a little bit more than half are undocumented, and then there's people who are eligible for subsidies, and others who are just above that threshold. And what we are, and you can see on the side there, the take-up, Medi-Cal, the enrollment today is about 14 million folks. There's about 300,000 eligible but not enrolled. So that has a relatively high take-up. Covered California, where there is premiums and cost sharing, the take-up is good, but it could be a lot better. And the question is, can we provide some additional affordability help? In addition to the undocumented, I want, which my colleague will talk about in a second, I outline a couple of people who might need more help. One is people who are in the quote-unquote family glitch, which is people who have employer-based coverage for themselves and their family, and so the worker can get coverage, but for the family is unaffordable. And unfortunately, because of a glitch in how the ACA was written and how it was interpreted, those folks do not have access to subsidies in the exchange. So that's something that we can address directly. Another is people who are just over 400% of the poverty level, where there are no subsidies available, who are now paying more than 10% of their income on coverage. We can and should provide some additional assistance to them. We live in a high cost of living state. 400% of the poverty level in California is 500 in America is 500% in California and 600% in San Francisco. So that would be appropriate, and to provide additional help within under 400% for people who need a little bit more help. In some cases, we're providing an 8-foot rope for people who are in a 10-foot hole, and a little bit more help will go a long way of getting them the care and coverage they need. And as you can see, again, there is a mix of the people in terms of the incomes that they represent. And so again, these two, we are heartbreakingly close to universality in California. We've gone from 20% to 7%, the largest drop. The two big steps are, one is introducing more affordability in covered California. The second is covering the undocumented, and to talk about that is my colleague Betsy Estudillo, who we've been from the California Immigrant Policy Center, who's been our co-chair on the Health for All campaign to expand coverage to all Californians regardless of immigration status, and I'll turn it over to her.
Great, thank you, Anthony. Can you all hear me? Yes. Okay, great. So, good afternoon, chairs and members of this committee. My name is Betsy Estudillo. I also go by Betsy, and I'm the Senior Policy Manager of the California Immigrant Policy Center. So I'm actually going to talk to you about a Health for All proposal. I'm going to give you some context. I'm going to share a little bit about some of the gains we've made on immigrant health, and then tell you how we actually get to a reality where Health for All is passed in our state. So to begin, a little bit about the California Immigrant Policy Center. So we were founded in 1996 in response to very harsh federal laws that excluded certain immigrants from vital social and public benefit programs. Today, CIPC continues to advocate for inclusive health and public policies that support the well-being of immigrant communities. So in order to better understand why exclusions are based on immigration status harm our state, I'd like to begin with some demographics and key data about the population in question, undocumented people in California. So according to the 2010-2014 American Community Survey, there are approximately 2.9 million undocumented Californians in our state. 1 in 6 of all California children have at least one undocumented parent, and 1 in 10 workers is an undocumented Californian. Undocumented Californians contribute $180 billion per year to our state's economy, and over half of undocumented Californians have lived in the U.S. for at least a decade. So in addition, immigrants are also very diverse. While we know that a majority of immigrants are Latinos, the fastest growing immigrant population are actually Asian and Pacific Islanders. In fact, in California, 16% of undocumented immigrants are API. As you can see, immigrants are heads of household, they're workers across a number of industries, and are longtime residents of our state. They provide incredible economic and cultural contributions and are deeply embedded in our social fabric. Take, for example, the story of Isabella and her mother, Daisy, who's on the right side of the slide. Isabella is a 12-year-old girl from Colombia who has suffered from cerebral palsy since she was born. In order to seek treatment for Isabella's condition, Isabella and her mother immigrated to California in search of health care, which they did not receive in their home country. For many years, Isabella wasn't able to access comprehensive care because of her immigration status. But thanks to Health for All Kids, she now is able to get primary care, physical and speech therapy, and is able to thrive. Isabella relies on her mother, Daisy, to take care of her. But Daisy herself is excluded from health care because of her immigration status. So what happens to Daisy when she gets sick? What does that mean for Isabella? So a little bit of more background. So what does it look like for undocumented adults like Daisy and not having access to health care? Well, the Affordable Care Act actually explicitly and unjustly excludes undocumented immigrants from receiving health coverage through Medi-Cal and selecting a plan or receiving subsidies through Cover California. Despite this federal exclusion, there is some care provided to undocumented people, and I'm going to talk a little bit about those in the list. So first, there is restricted scope Medi-Cal, which provides low-income undocumented adults with emergency care. There is pregnancy-related care through Medi-Cal, which gives immigrant women pregnancy-related medical care, as well as all other primary and specialty care. As I mentioned, we do have Health for All Kids, which gives undocumented children access to comprehensive full-scope Medi-Cal. And we also have a safety net, where some counties provide some care to undocumented adults through their safety net systems, but there are still many counties that do not. And then for DACA recipients, low-income DACA recipients are currently eligible for full-scope Medi-Cal as individuals who fall under a benefit eligibility category known as PRU-Call. And I know there's been recent news around the decision to terminate DACA, but the Department of Healthcare Services has clarified that DACA recipients who lose their deferred action status will still continue to be eligible for healthcare under full-scope Medi-Cal. So, however, this patchwork of care still leaves many undocumented adults with no access to health care. As a result, 58% of those who remain uninsured are undocumented adults. This is why it's essential that we talk about undocumented Californians as part of the conversations to get to universal coverage. So I'm going to walk you through some past legislative actions that the Health for All campaign coalition has moved forward. CIPC, Health Access California, and our Health for All coalition launched efforts to make healthcare more inclusive for undocumented immigrants. And here are some key successes in the Health for All campaign. So our first success was Health for All Kids, and in 2015, immigrants and healthcare advocates worked together to pass SB 75 and SB 4, known as Health for All Kids. Health for All Kids was enacted in May 16th of 2016 and providing full-scope Medi-Cal to undocumented children under the age of 19. Since then, over 200,000 undocumented children have had access to comprehensive health care. The next bill we worked on was SB 10, which was our 1332 waiver bill. In 2016, SB 10 directed the state to apply for federal 1332 waiver, allowing undocumented immigrants and DACA recipients to purchase unsubsidized coverage in Cover California. However, the waiver was rescinded due to concerns over the new administration targeting of immigrant families. And then last year, the Health for All Young Adults budget proposal aimed to remove a critical barrier to health access by providing full-scope Medi-Cal to undocumented young adults. The Assembly and Senate did include it in their budget investment, but however, the proposal was not included in the enacted 2017-2018 state budget. But we have an opportunity to build on these legislative actions to bring us closer to universal health coverage, and we can do that this year with Health for All. To reiterate, Health for All is a proposal that ensures that Californians have access to health care regardless of their immigration status. There are some legislative proposals out there. In mid-December, the Assembly released their budget blueprint that highlights their priorities for this year, which includes expanding Medi-Cal access to cover all uninsured. We appreciate the Assembly's continued support from last year, which I know many of you supported and championed Health for All Young Adults, and including Health for All in their budget blueprint this year. We look forward to working with all of you very closely in the budget process. And then on the Senate side, Senator Ricardo Lara did recently introduce SB 974, which would provide full-scope Medi-Cal to low-income undocumented adults. So lastly, I'll just say that it's very important to note that the nation needs California's leadership now more than ever. And with Health for All, we'll be able to help our families and communities thrive and create a model for the nation. Thank you.
Thank you, Betsy. And again, we greatly appreciate partnering with CIPC and with the dozens of groups that have been working on the Health for All coalition over several years. And we think that we can make another large stride this year on that front. And again, we are so close to universality, but I do want to also talk that there's also work to do with regard to not just making sure that people can get access to care, but also that that we address issues of cost and quality and equity. Some of this is already an agenda that is already in proposed and in front of you. Again, you took an important step last year with SB 17 on prescription drug prices. There are several other bills to address the issue of prescription drug prices, whether it's with regard to pharma's practice of providing gifts to providers to possibly have an impact on subscribing, or the issue of pharmaceutical benefit manufacturers that Chairman Wood is working on, or work to just maintain and extend caps on co-payments for specialty medical drugs. I think there's also a lot of work on the issue of consolidation, which has served to drive up prices in our healthcare system, including bills on working to provide oversight over health plan mergers. Again, Chairman Wood has that bill, and then another bill in the Senate, or that has passed the Senate, is now in the Assembly on the issue of unfair and anti-competitive hospital contract provisions, which have served to have led to Northern California premiums being significantly higher than Southern California rates, as an example. Ultimately, whatever system we put in place, we need to address the issue of prices in our healthcare system. Single payer is useful in building a purchasing pool that is big enough to be able to bargain for a price, but you still need a mechanism to change that, and whatever system you have. And it is, at the end of the day, the fundamental issue of our American healthcare systems. Americans do not use more healthcare than any other country. It is the unit price that is much more expensive in this country than any place else, and we need a mechanism to review and benchmark and look at those prices. I know my colleagues in business and labor will talk more about that. And then finally, we need to have more accountability over our managed care plans, including the ones that are publicly financed through our Medi-Cal system, and make sure that there is accountability for quality and equity. If we are going to have plans, whether they be public, private, for-profit, or nonprofit, we want to make sure they are accountable for actually providing the care that we're contracting them for. Another option that is that the committee should look into is with regard to making sure that no Californian, especially those that are in rural areas, are left without any coverage options whatsoever. The issue of bare counties is one that some other states have dealt with, and we want to make sure that whether it's that north of Sacramento region or Central Coast or Central Valley, that Californians are not left without a coverage option. And if there is an issue with, and if that issue does come about, that we use the Medi-Cal infrastructure we have to make, whether through the Medi-Cal managed care plans or the existing program, to make sure that there's an option. The final thing, to wrap up, is that, again, we think that there is an aspirational agenda here that is complementary with the broader vision that is on a different timetable to that in the next year, in the next couple of years, that we can achieve without federal approval, to stabilize the market and resist the sabotage, to get to universality and affordability, and to start dealing with the issue of cost, quality, and equity. The argument that has been made by some on, Senator Ted Cruz, among others, say that the Affordable Care Act was a slippery slope to single payer, and I think that he was wrong. He got the metaphor reverse. It's not. It is the fact that we are closer, but it's not a slippery slope down the mountain. It's scaling up the mountain. It's how can we, and the question is, how do we continue to go up the mountain to the vision of everybody having the care that they need when they need it without financial barriers? And what we think is that these steps actually get us that much closer, are building the infrastructure, the political infrastructure and the policy infrastructure to get to that goal. And that's why we think that we shouldn't wait for federal approvals or the other obstacles are in our way. We can take steps now to get that much closer to the healthcare system that we all deserve. Thank you very much.
Thank you.
Next, we'll have Sara Flocks with the Labor Federation, as well as Peter Finn from the Teamsters.
Good afternoon. My name is Peter Finn. I'm the Secretary Treasurer and Principal Officer of Teamsters Local 856 and the Recording Secretary of Joint Council 7 of the Teamsters, covering 100,000 members throughout Northern California. I wanted to first thank the committee for the opportunity to be here today. Healthcare is something that I am very passionate about, and along with affordable housing, the skyrocketing cost of healthcare is among the biggest challenges facing middle-class families here in California. This is certainly the case for the workers that we represent. Our local union, Teamsters Local 856, represents 13,000 members working at nearly 200 different employers in both the public and the private sector, in every industry you can think of, from school employees to law enforcement, from hotel workers to airline mechanics. And while the workers we represent are very different, there's one thing that is consistent across all industries and sectors where our members work. Healthcare is the most challenging issue we face at every bargaining table. The challenges workers face around healthcare are significant. The skyrocketing cost of healthcare is making the employee share of monthly medical premiums reach unaffordable levels. And as more and more money is being diverted from salary to healthcare, there is downward pressure on wages. We've also seen rising healthcare costs result in fewer plan choices, benefit level reductions, and worst of all, more employers are attempting to limit access to healthcare through the use of part-time and temp workers. I spend most of my time bargaining contracts alongside the members that we represent. In negotiations, when I start the discussion on healthcare with an employer, I always begin by talking about how it's a shared problem that we need to solve together. I make it clear to the employer that they did not create the problem, that our members didn't either, that the skyrocketing cost of healthcare is something that has been dropped in our lap, both employers and workers left holding the bag, left trying to figure out how to pay for it. The problem is that healthcare costs just keep going up, and it feels like there is no end in sight. It is becoming unsustainable. For example, we represent workers in many school districts in the Bay Area. These districts contract with CalPERS for medical insurance. But guess what? Even CalPERS, with its huge statewide buying power, can't keep rates down. The monthly premium for a basic Kaiser family plan is now over $2,000 per month. That's $24,000 per year. Again, this is not a Cadillac plan. This is a basic Kaiser family plan. At the two biggest school districts where we represent workers, the employer pays 80% of the Kaiser rate. At first glance, this doesn't seem unfair. The employer is paying nearly $20,000 per year for every employee in family medical. But the story gets worse when you look at the paycheck of a worker. For example, a custodian makes just under $20 an hour, or $40,000 per year. After taxes, take-home pay is just over $2,500 a month. Then you have to pay your 20% of your Kaiser family plan. That's over $400 per month. After paying that $400 per month for health care, that leaves just over $2,000 for rent, for clothes for the kids, for groceries, and other expenses of daily life. And the school district's not the worst of it. At one Bay Area county, where we just recently organized workers, the employee monthly share for the Kaiser family plan was $800 and $1,000 for other plans, particularly in the context of the affordable housing crisis that we face throughout the state. These outrageous healthcare costs are simply unaffordable. In the private sector, maintaining quality health care has come at the expense of wages. Our members diverting salary increases to pay for health care. For example, in the hotel industry, where we represent 1,000 workers in San Francisco, health care now costs over $12 per hour. Yes, $12 per hour. That's $25,000 a year being diverted from wages to health care, money that could otherwise be spent in the local economy to help workers manage the ever-increasing cost of living. In our experience, it is undeniable that the out-of-control healthcare costs are a key driver in wage stagnation. Skyrocketing healthcare costs have also led to elimination of plan choices and reduction of benefit levels. Non-Kaiser HMOs and PPOs being eliminated to cut costs. And when we can keep those options, deductibles and copays are going up. And most disturbing of all, employers in both the public and the private sector are dealing with these spikes in healthcare costs by denying access to medical coverage through the use of part-time and temp workers. At one employer we just organized, of 1,800 workers in the unit, only 600 qualify for medical benefits. This abuse of part-time and temporary workers is a direct result of the impact of skyrocketing healthcare costs. In addition to negotiating contracts, I'm also a trustee on a union Taft-Hartley trust fund that covers Teamster members, their families, retirees. The trust fund contracts with Kaiser, Anthem Blue Cross, and offers a self-funded PPO where the trust fund pays the claims directly. In the years following the 2015 passage of the Healthcare Transparency Law, SB 546, the pressure from Sacramento seemed to have an impact. And we saw a few years of low rate increases from Kaiser and Anthem Blue Cross. As a trust fund, we did everything we could to take advantage of the tools available to us to keep rates down. We hired a data warehouse company to analyze utilization with the data we were now able to obtain from the insurance companies, and we grew our trust fund by adding participants. In fact, we nearly doubled the size of our trust fund. Unfortunately, it appears we have completely exhausted the positive impact of the transparency law, and the days of huge double-digit increases are back with us. And back in a big way. Listen to this. Kaiser just announced they are increasing our rate by 15%. The non-Kaiser HMO is worse. Anthem Blue Cross is proposing a 25% increase. That means the family rate will be going up $500 per month. And whether it's the employer paying for it or the employees, it's absolutely unsustainable. On our self-funded direct pay PPO side, I was told by our experts the only way to reduce cost was to create a skinny network of hospitals. In other words, cut out the hospitals that charge the most. But here's the catch. That would eliminate 30% of the hospitals that our members depend on using. And of course, that's a non-starter. As you can probably guess, I'm frustrated. I'm disheartened. The status quo is just not sustainable. I can't help but feel like we're at a breaking point, that we're out of options for workers and employers to solve the issue of skyrocketing healthcare costs at the negotiating table. We need a strong legislative solution that controls costs throughout the system, from hospitals to insurance companies. And I want to close by making it clear. Working people across the state stand ready to work with you to accomplish this goal and solve this problem. We can't afford not to. Thank you.
Mr. Chairs, members, Sara Flocks from the California Labor Federation. The Labor Federation represents 1,200 affiliated unions just like Peter's, that both bargain for and purchase health benefits for our 2 million union members and their families in California. I just want to start by thanking the committee and the staff for the great work you've done in these hearings. I've watched and rewatched everyone and feel like I have a PhD now in healthcare. So thank you for this very important work. And I just want to start my presentation by saying that the Labor Federation supports single payer. We have, over the decades, supported bills to move towards a single payer system. We also support SB 562. So in my presentation today, I'm going to talk to the committee about options that move us closer to the goal of single payer and to a universal health care system in this state. So at the December hearing that this committee had, Governor Shumlin from Vermont offered some recommendations that I thought were very apt to start my presentation. He said that the rising cost of health care also applies to universal health care. Whether you pay for it through public funds or through the current private system that we have, no system will work unless we find a way to cut the rising cost of health care. And he recommended to California that we get cost containment right first, and then we can consolidate into a single-payer system. And the Labor Federation knows how important cost containment is. You can't listen to Peter talk and not feel the urgency of having to be able to get costs under control. And we've tried every year to focus on small parts of the industry to do that. We've moved bills around the price of prescription drugs. We supported Mr. Wood's bill on pharmacy benefit managers. We've done work on insurance companies and health plans. And we've looked at the anti-competitive pricing of hospitals. But through all of that, we still see that every dollar that we have to spend on rising healthcare prices is a dollar that's coming right out of workers' pockets. And so we know through this fight how difficult it is to tackle the issue of cost containment, because we are going up against a billion-dollar industry. But it is critical. It is critical both as a first step to single payer, and it is critical to working people and to Californians. So let me see if I can use this. Okay, so this is just an example of what we're suffering from. The two lines going up are premiums and employee contributions to premiums. The flat lines are wages and inflation. And in that gap, that is the hole where our middle class is falling. That is what is eating up our middle class in the state of California. So on this slide, you also see, and this has been emphasized over and over, that the U.S. spends almost twice what other countries spend on health care. But an interesting part of this slide is if you look at the dark blue line, that's public expenditures. That's kind of on par or less than what a lot of other countries spend. Our real problem is in the commercial market, in the market where we have our trust funds, the individual, the small, the large group, the self-insured. That's where spending is getting out of control. And what we can see is that all of these countries here, the one thing that they all have in common, and all of these countries with universal health care have in common, whether they're a single-payer system or a multi-payer system, is that the government regulates health care prices and controls costs throughout the system, including in the commercial market if they have one. And I want to emphasize this point again, and also emphasize what Anthony said, is that it really is the prices. Because healthcare spending or healthcare cost is just price times utilization. And if you can see from this graph, once again, all the lines going up, those are prices. The lines going down is utilization. So in the US, we are using less healthcare, getting worse health outcomes, and yet paying more for every single doctor visit, every single hospital service, every single prescription drug than people pay in other countries. And so prices are what are driving overall costs in the system. And Peter raised SB 546, which is a bill that we did on health plan premiums. Today in San Francisco, DMHC is having a public hearing looking at the rate filings of health plans. And if you look through those the filings, you will see the same thing as this slide. Utilization remains flat, prices are skyrocketing, and that is what is driving premium increases. The other problem that we have is that not only are prices high, but they vary wildly. So this is just an example of the range of MRIs in the 100-mile area around San Francisco, which range from $475 to over $6,000. Sometimes you have hospitals right next door to each other that are charging this variation in prices. Sometimes you have patients in the same hospital for the same service that are paying wildly different prices depending on who has their coverage, if they're on Medicare and Medicaid. So we have a system that not only where the prices are too high, but they are opaque, and they're all over the place. So there's massive price discrimination. And so what do we do about this? Peter has said that CalPERS and some of the largest employers and the largest unions in this country have tried to do everything they can to gain control over the problem of costs. They've tried to use the tools of transparency. They've tried to do benefit design, reference pricing. We have the offers of trying to go to narrow networks, to excluding hospitals. All of this we've tried to do ourselves as purchasers to really get costs under control. But we are still at the point where the prices are going up, we keep having to pay them, and it is getting to the point to be a real crisis. It's unsustainable. And that is why we really do need legislators and do need the government and policymakers to take bold action to really effectively do cost containment across the healthcare industry. All right, I know that's the easy part, is the analysis of the problem. Okay, what do we do? So I would say that even though Amazon and JP Morgan Chase and Berkshire Hathaway have gotten a lot of play in the last couple weeks, we don't really need big companies trying to figure out what to do about cost containment in this country. We already know what to do. We already have some really incredible examples in this country of how we can start to get costs under control. So I will start with Medicare. Medicare is a program that, everyone, what I think Governor Shumlin said was the only good reason to turn 65, was to get onto Medicare. This is a system that is transparent and public in the way that it sets rates. It sets rates that are paid to hospitals, to doctors, and for outpatient services. It's a model that not only could serve as a model for California, but has also been adopted by other countries, including France, Germany, and Australia. And they've applied it way more broadly than just for people over 65. They've applied it to the commercial market as well. And you can see that in the slide that I presented at the cost savings that they have. It also is flexible in that it's not a one-size-fits-all rate. Rates are adjusted. They're adjusted for regional differences, for wages, for outliers, for hospitals that are, or services that are disproportionate share, that serve more low-income or Medicaid patients. And so there is some flexibility built into this system. Another great thing about Medicare as a model is that there is Medicare Advantage. And so this is an option for private health plans to provide coverage to Medicare enrollees. And so in California, 40% of Medicare enrollees are in Advantage plans. And this is where there is a capitated rate that is paid. So it's not just a model for fee-for-service, but for other payment models. And yet, it still retains Medicare's model of setting rates and controlling prices, to controlling the price that is paid to providers across the system. And then there's Maryland. You had a great presentation from Maryland on the system that they use. They use something called all-payer rate setting. This is a model that is also used by many other countries to control cost and prices. It's France, Germany, Japan, the Netherlands, and Switzerland. And Maryland, since the 70s, the government has set the rates that are paid to hospitals. And so they use a Medicare-like model, and they say, okay, we don't care what you charge, but this is what we are going to pay you. We are going to control the price. And those are the prices that are paid by everybody, by Medicare, by Medicaid, by the self-insured, and by anybody covered in the commercial market. Medicare did run into some issues in that, Maryland ran into some issues in that when you squeeze the balloon at one end, sometimes it expands at the other end, and so you have to be careful. And so one of the issues was that if you just look at price, you may have a growth in the volume of services, in the intensity of services. It might not account for, if you're just looking at hospitals, shifts to outpatient settings that are not subject to rate setting. And even in that situation where you're controlling price, you might still have an increase in overall spending because you're not looking at the full balloon, to continue the example. So Maryland responded to that issue by, in 2014, adding a budget cap. So basically saying we're going to look at overall how much healthcare spending there is across the system while keeping in place the rate setting that they've had since the 70s. And hopefully we're going to see some good results from that. So there are models out there for how we can move forward on effective cost containment that will really do something for Peters Local and for people in the commercial market. And so I'm not going to leave you with a full proposal, but we do have some kind of core principles as we move forward looking at cost containment. One is that it builds towards a universal single payer system. That this is one element of it, a key element, and an element that will impact people right now. We need to really get control about how much our people are spending on healthcare. That the cost containment has the overall goal of containing costs, which you need to look at as both the price and utilization, that it increases quality, that it improves health outcomes, one, because we care very much about our members' health, and two, because it just makes good long-term sense to keep people healthy, and reduces disparities in the system through a form of regulation. Fourth, that it allows for flexibility to assure the financial stability of the regulated entities, because we want to make sure we have fully functioning hospitals and clinics in all areas of the state. We have members in very rural districts from Northern California to far Southern California, and we want to make sure that they have access to the hospitals that they need to go to and access to the care that they need, as well as to account for reasonable costs, including labor costs. Hospitals and the healthcare industry is a big employer in the state. It's a big contributor to the economy. We want to make sure that it stays that way and that our brothers and sisters who are healthcare workers and who build hospitals and who provide health food services and janitorial are able to maintain a high standard of living. And also that this system operates with maximum simplicity and transparency, so that we all move from this really opaque healthcare system that we have right now to one that we can all understand and can access. And I will add one of the bullet points that is not on here is just urgency. That tackling costs and doing cost containment, even if we say that it's a step on the road to single payer, it's a big job, and it is an urgent job, and it is one that is going to affect every single Californian and every single California business. And so it is a task that is worth taking on. I know this committee has spent hours and hours preparing for this task and is very well prepared, and we look forward to working with you to achieving this goal. Thank you.
I think I probably butchered your name a couple times, so I apologize, Mr. Arensmeyer.
Correct.
There, okay, got it. Maybe I got it right from the founder and CEO of the Small Business Majority. Please, thank you.
Well, thank you, co-chairs Arambula and Wood and the entire committee. I'm John Arensmeyer, founder and CEO of Small Business Majority. As a representative of more than 3.8 million small businesses in California, we're pleased to offer testimony today in support of common sense solutions to ensure California's businesses and self-employed entrepreneurs have access to quality, affordable health care. We are a national small business advocacy organization founded 12 years ago in California with 3 offices in the state and 7,000 small business owners in our network out of 55,000 nationwide. We are founded and run by small business owners to ensure America's entrepreneurs are a key part of a thriving economy. We actively engage small business owners and policymakers in support of policy solutions, and we deliver information and resources to entrepreneurs that provide small business growth and drive a diverse and inclusive job-creating economy. A key part of our work over the past 12 years has been to advocate for policies that help small businesses, their employees, and self-employed entrepreneurs. access affordable and comprehensive health coverage and care. Today, I'll discuss several proposals we believe are crucial to ensuring and expanding this access. Over the past 5 years, the ACA has provided health care to 24 million individuals nationwide who otherwise couldn't access coverage, many of whom work for small employers or are themselves business owners or self-employed. In California alone, more than 5 million people have insurance thanks to the new health care law. It's important that this committee and everybody realize how important the ACA actually is to small business and to entrepreneurship in this country and this state. Unfortunately, prior to the law's enactment, small businesses and their employees comprised a disproportionate share of the working uninsured. Indeed, in 2011, nearly two-thirds of the nation's uninsured workers were self-employed or working at a company with fewer than 100 employees. And when they could access health coverage, small businesses paid an average 18% more than their larger counterparts, usually for less comprehensive coverage. I should point out that since the enactment and the implementation of the ACA, the rate of increase in the small group market has dropped. The annual rate of increase has dropped from 10.4% to 5.2%. Those are national numbers, but the numbers in California are not far off. It should come as no surprise that the scientific opinion polling we've conducted last year found that 6 in 10 small business owners support the ACA, despite all of the misrepresentation and partisan noise surrounding its enactment and implementation. The ACA is the first meaningful health care reform to help address these needs and disparities, and it's been particularly important for California's small businesses and self-employed entrepreneurs. In particular, the individual marketplace has been crucial to expanding access to quality, affordable health care for the small business community, with 8.1% or 3 million self-employed Californians, 8.1% out of the 3 million self-employed Californians is 370,000 total enrolled on a plan through Covered California in 2015, compared to just 2.9% of all workers. Employees of small businesses totaling 5.1 million in California are also more likely to have benefited from the ACA, with roughly 21% of small business employees gaining coverage in California through both the individual marketplace and the expansion of Medi-Cal. That's 13% in Medi-Cal and 8% in Covered California. These statistics illustrate how California has been the leader in ensuring access to quality, affordable health care thanks to its creation of a robust individual marketplace, easy enrollment in the small group marketplace through Covered California for Small Business, and vigorous marketing and education campaigns. However, as we've heard, national efforts to chip away at the health care law or repeal entirely threaten this progress. Recent proposals to undo key provisions of the ACA through legislation and executive action threaten to disrupt the marketplaces and in turn harm small business owners, their employees, and self-employed individuals. While we believe certain provisions of the ACA can and should be improved, undermining the ACA eradicates hard-won benefits for America's entrepreneurs, potentially causing a rapid rise in health care costs and creating tremendous economic instability. California small businesses look forward to the day when one's employment and income status don't govern access to quality, affordable health care. But in the short term, California can and must take immediate steps to protect its citizens and its small business community by enacting practical, achievable reforms that will strengthen California's marketplaces and prevent huge increases in health care costs while potentially laying the groundwork to achieve the long-term goal of universal coverage. Today, I'll focus on 3 key areas: market stability, expanded access to coverage, and cost and affordability. First and foremost, steps must be taken to improve the stability of the individual marketplace, especially in light of the federal repeal of the individual mandate penalty. A strong individual marketplace is vitally important for owners and employees of small businesses that aren't able to offer group coverage. That's over half of all small businesses. And especially for the roughly 3 million solo entrepreneurs in California who have had no other access to coverage before the ACA. The ability of self-employed individuals and entrepreneurs to purchase affordable health insurance promotes a robust small business economy by reducing job lock, allowing workers who previously felt tied to their job by their large employer benefits package to strike out on their own entrepreneurial path or join thriving small businesses. This is why California must pursue innovative state solutions to encourage younger and healthier individuals to stay in the system, which is necessary to ensure a robust, competitive, and affordable marketplace. California has already worked to stabilize rates despite uncertainty regarding federal cost-sharing subsidies, and we encourage the state to continue to find creative solutions to stabilize individual marketplace. As such, we have a list of recommendations that would help ensure a healthy and thriving marketplace for California's entrepreneurs and small business employees. First, we encourage lawmakers to pursue legislation that would require all Californians to participate in the health insurance risk pool. It's absolutely critical that California reinstate an individual mandate or an equivalent provision to ensure a stable and healthy marketplace for California's entrepreneurs. By encouraging young, healthy people to join and remain in the system, we can also promote affordability for everyone. We also caution against allowing so-called junk insurance plans that don't conform to the ACA. These plans would weaken the larger individual market while failing to provide adequate coverage. Specifically, we encourage all of you and your colleagues to support legislation like SB 910, which would prohibit insurers from offering short-term, limited-duration insurance plans, and in so doing, help to protect consumers from plans that fail to provide adequate coverage. To protect the robustness of the small group market, California should continue to prevent businesses from forming association health plans, including retaining the current ban on new multiple employer welfare arrangements, or MIWAs. While AHPs and MIWAs might no doubt offer plans with lower costs for some small businesses, they largely benefit entities with larger, healthier employees. This creates separate risk pools, creating a problem when you leave other employers in the core small group market. We can't have bifurcated, balkanized markets. We have to have a robust, large enough market that everyone's participating in. AHPs also often don't cover essential health benefits and aren't governed by rules preventing insurers from charging more based on traits such as gender or having a pre-existing condition. California is already a leader in preventing abuses from these types of plans, and we hope the state will continue to push back against national efforts that would undermine our state protections. Second issue is access to coverage. In order to have stable health care marketplaces, it's critical that small business owners, employees, and self-employed entrepreneurs have access to quality, affordable health care. California has done an impressive job of promoting its health care options by providing online enrollment and communicating the marketplace's benefits through education and outreach. Here in California, our team at Small Business Majority has conducted more than 500 workshops for small businesses across the state, reaching nearly 20,000 Californians directly through our health care events and more than 200,000 overall through our free health care resources for California small businesses. Based upon our extensive work on the ground, educating our state small businesses and listening to their needs, we recommend the following actions to further expand access to affordable coverage. The first and most important is Medi-Cal. Expanding Medi-Cal under the ACA has played a crucial role in reducing California's uninsured rate, especially for small business employees and the self-employed. For example, a recent study found that 13.3% of self-employed Californians and 52% of small business employees gained coverage thanks to Medi-Cal expansion. Roughly 1/4 of California's self-employed population was insured through Medi-Cal in 2015. I want to repeat, 1/4 of California's self-insured population insured through Medi-Cal, while more than 1/3 of Californians working at companies with 10 or fewer employees, that's almost 100,000 employers, were enrolled in the same year. Yet 2.9 million Californians still don't have insurance. Of those who are uninsured, 1.8 are employed, with 44% of them working at a company with fewer than 50 employees, while 1 in 6 are self-employed. 1 in 3 of those without insurance in California have annual incomes below $25,000, meaning they are likely eligible for Medi-Cal. Further expanding Medi-Cal and continuing to educate Californians about its benefits would help low-income, small business employees and self-employed individuals obtain coverage. Additionally, we encourage the legislature to expand Medi-Cal to include undocumented Californians. Extending this coverage would drastically decrease the number of remaining uninsured in the state, as roughly 1.8 million undocumented Californians are without health care coverage, more than half of the total uninsured. These people, many of whom run or work in small businesses, are accessing our healthcare system in an inefficient manner without any way to pay for their care, thereby adding to the instability of the system and increasing healthcare costs for everyone else. And lastly, there's the all-important issue of cost and affordability. California's legislators must pursue additional policies and improve cost and affordability for Californians. Our scientific polling has shown that small business owners are deeply concerned with the cost of prescription drug coverage and that these rising costs are hurting their bottom line. As a result, they're strongly supportive of a number of policies that aim to bring drug costs down. And additionally, our polling shows 85% of small businesses support the ability of government to negotiate drug prices. We encourage lawmakers to consider proposals like AB 587 to allow pooled purchasing power for prescription drugs. California's lawmakers can further promote affordability by enacting policies that require health plans to spend more on health care and less on administrative costs and profits. One option is to codify a medical loss ratio into California law to reinforce the state's commitment to affordability. Locking into an 80-20 ratio in case federal law loosens this requirement would be a good first step. We encourage further research to determine if a higher ratio is economically feasible. Obviously, we have to have a system under the current system where insurance can be offered by private insurers, so we don't want a ratio that's going to make that unsustainable, but I think we can look at maybe doing better than the 80-20 rule. Another example would be to consider a public option to allow Medi-Cal to compete with private health insurers in the open market. Consumers would have the choice to buy into these programs at their own cost, which would increase competition, provide more coverage options, and help lower costs. Additionally, this type of public plan would ensure that all areas of the state have access to competitive coverage. Additional options include making plans more affordable by providing additional financial assistance to Californians who are purchasing subsidized plans through Covered California, specifically by increasing co-payments or cost-sharing measures to those who qualify for federal ACA subsidies. California can also promote affordability by working to keep premiums down for all individuals. As Anthony mentioned, fixing the so-called family glitch is also a way to ensure more Californians have access to affordable coverage. This is particularly important for employees of small businesses, many of whom can't afford to provide coverage to dependents. We encourage the state legislature to consider providing a state subsidy for spouses and dependents who are currently unable to receive a subsidy through Covered California due to the fact that the primary insured family member meets the employee affordability standard under the law. Finally, we encourage lawmakers to support legislation like SB 538, the Health Care Market Fairness Act, a bill introduced in the previous legislative session to promote hospital contracting reform to drive down costs. Empirical evidence shows that the provider consolidation and unfair contracting are a key driver of increases in health care costs, and the bill addresses some of the most coercive practices by providers that have no relation to value and serve only to fuel unjustifiable increases in price. In sum, the Affordable Care Act has led to significant gains for all Californians, and particularly to small business employees, employers, employees, and self-employed. Thanks in no small part to the proactive attitude California has taken to establishing a robust marketplace that has made it easy for individuals and small employers to access affordable coverage. To continue this progress, California lawmakers should consider additional common sense solutions to improve market stability, expand coverage, and make health care even more affordable. This can all be done in parallel with considering the many suggestions for long-term universal care, including single payer, and we encourage the legislature to work on both tracks at the same time. Thank you for the opportunity to comment on this important issue. Look forward to answering your questions.
Thank you very much. Appreciate it. Questions? Mr. Chu.
Thank you. I have a lot of questions. I'll try to keep it concise, but I'd love to just drill down to the next level of detail from where your presentations were. So starting first with health access, I know there's been a lot of discussion about how to expand affordability help and the idea that no one should spend more than a percentage of income on premiums. That all makes sense to me. Question to you, do you have specifics on this? What numbers are you talking about? How much would it cost? I'm very interested in that idea.
I think we are currently working with both our colleagues in the advocacy community and in the academic community to come up with specific numbers. But I think the Affordable Care Act gets us pretty close to the way there. There is that guarantee of you don't have to spend more than a certain percentage. If you don't have the benefit of employer-based coverage, if you're in an individual market, you don't have to spend more than a certain percentage of your income on premium. For a silver level plan is something that is extended to folks under 400% of the poverty level, which is about $48,000 for an individual and $98,000 for a family of four. It is the issue of the family glitch for those workers is something is one of the holes that needs to be plugged. The question is, for those folks who are just over 400%, we do have data that suggests that where the populations, the people who are just over 400% tend to be in high cost of living areas and older, because there is, as the Affordable Care Act does limit, but does allow for a 3-to-1 age band between the premiums for an older person and the youngest person. So we think that it is doable to do that. We also think it's important to also provide some additional assistance. The vast majority of people in covered California buy silver or better plans, and in fact, the new enrollment data suggests that we even had more people picking up gold plans, especially with the cost-sharing reduction workaround that was developed by Covered California in light of the Trump administration attack. But frankly, we want to make sure it's always affordable, so that people don't feel like they need to get to that bronze plan, which is that $6,000 deductible plan. Which we want to make sure they're at least at that silver plan, where even for those who have a deductible, most of their care outside of hospital care is covered outside of the deductible, and so people have access to the care that they need. In terms of costs, I would say that we are still working on a number. The LAO gave you some estimates on Monday, and I think we are trying to refine and see what kind of efficiencies we can provide, what kind of savings and offsetting savings there are. But I would say that in terms of scale, that I know you had your dialogue with the LAO on Monday, and I would say that to do the whole thing of both the additional affordability in covered California and the Health for All, expanding Medi-Cal and undocumented, would be less than, say, what we raised under Prop 30. Like it is not the sort of the tens of billions of dollars, for example, that we would have lost under the various federal proposals that we were considering last year. That it's a scale that is doable. We actually hope that we can even make progress within the budget, but to do the whole thing would require some raising revenues, but on a scale that would be certainly manageable.
Okay, and then a follow-up for that. You talk about healthcare prices, no unjustified medical bills beyond benchmarks. Do you have a specificity on what that looks like? It sounds like the all-payer cap from Maryland, and I'm not sure if you meant that to be the case, but curious what.
I think there are different models about how you could do this. I think you could look at again, especially since so many providers do take Medicare, looking at that as a starting point, and then seeing where there needs to be adjustments accordingly, similar to how the surprise medical bill law that this legislature adopted not too long ago did, where you start with a certain benchmark, but then allow a dispute resolution process to go over it. I think there are other models as well. So I think you could. Maryland's one model. We can create our own California model, but this is the mechanism that we will have to have, whether by in order to deal with the issue of why are prices so high and why do they go up higher. I mean, as we said with prescription drug prices, it's when those prices go up by 300, 400, 500%, it's not like the medication became 300, 400, 5% more effective. So then what is the issue? And again, we do this in the public utility world as well. And that's maybe not the perfect model, but we recognize that when there is a concentrated monopoly for an essential or oligopoly for an essential service, that we try to say that the companies providing it can get the revenue they need to provide the service, but they need to justify how those expenses are. And then there are debates about with regard to the investments they make, with regard to building their telecommunications network or cable network or whatever.
Okay. Just one comment, I know, on the issue of healthcare at all, and I think a number of you know this, but I'm prepared, and I think there are a number of us who are prepared to author that bill, co-author that bill, vote on that bill today. So I just want to say that this is something that should have happened years ago, and I think we need to get that done. A couple questions to the California Labor Fed.
Just want us to say thank you for that.
Sure. So, are you proposing that we consider the Maryland all-payer rate model here in California? I know you laid it out, but I wasn't sure if it was a proposal coming from the California Labor Fed.
No, we were basically what we did for our proposal was put out a number of different models and our core set of principles and say that we definitely, Maryland is a very, very different state than California. We need to look at our state, the level of managed care we have, the size, the number of hospitals, everything, and find a model that fits our state. And so that work needs to be done. If I had more time, I could have gone into a whole lot more examples, including Massachusetts and Vermont and West Virginia, Japan, other countries, and also, Anthony raised utility-style regulation. There's examples in the non-healthcare sphere as well that could be useful. And so I think we need to take all of these pieces that we have and all of the experts that you've heard from and figure out what's the best fit for our state.
Okay, and I just want to observe, I absolutely appreciate all your core principles, building toward a universal system, containing costs, increasing quality, improving health outcomes, simplicity, transparency, but obviously these are principles, and I think we'd all love kind of concrete proposals coming from stakeholders so that we can start sifting and comparing. Another question is around which of these options would require federal waivers. So I'm assuming public option, if we were to move forward in the public option world, that would require a waiver. Maryland all-payer rate would require. I've been reading different things about that. No, we could just expand that here.
I mean, the point of my slides was that was to try to sift through and provide the committee options of what we believe is doable without federal approvals, because we are concerned that even proposing something to the federal government at this time would open a door that would have unintended consequences. I mean, and I say that as somebody who, working with my friends at the Immigrant Policy Center, had a 1332 waiver, on the federal government's door about trying to open up Covered California to all Californians, regardless of immigration status. But that, I think it was wise to have withdrew that, because you didn't even want to set the precedence of what the federal government could have done with that. So it's certainly the case that there may be versions of a public option or versions of an all-payer claims database that would require some federal approvals.
Maryland had to get waivers.
And Maryland do it, but I think that there are versions of it that do not require it, and that's what I'm saying. So it's certainly the case that there are probably versions of it that are more robust, but we do at least see a path where it does not require the sort of the roadblock of federal permissions, either administrative or an act of Congress.
Okay, and then just a final question I'm trying to wrap my brain around. So I think we all heard former Vermont Governor Shumlin tell us, and it was really interesting to hear from him, from his perspective, we need to tackle cost containment first. And I think that makes sense, except for the fact that in every state in the country for decades, we've all been trying to tackle costs. And it's been very, very difficult, and we haven't been able to figure it out. And I know Shumlin said we should figure out how to tackle costs before considering single payer. I'm not sure if that's your perspective, but it seems to me that single payer has an obvious solution in how you tackle costs. And so how should we think about various cost containment efforts and how we parallel track how we think about single payer versus thinking about tackling cost containment? If we've been all, I mean, at this point we can all agree on principles, but we have not been able to tackle costs for decades. So how should we think about that?
Well, I'll go back to what Governor Shumlin said in the hearing, and what I remember him saying is that he was saying that even in a universal healthcare system, even in a single payer system, you are still going to have the rising prices of healthcare services. You definitely get a huge one-time and ongoing savings from eliminating insurance companies. You get rid of them and the bureaucracy and the administration. But you still have to reimburse and pay hospitals, doctors, prescription drug companies. And so there needs to be a explicit, effective, robust cost containment element that is part of any single payer universal healthcare system. And that has to be explicit. And so I think that since that is a really difficult piece, like you said, we've been grappling with this for decades upon decades. We need to figure out how to get this right and take bold action so that we are able to reduce the cost of healthcare as we move to a single payer system, which results in having to pay less on the public side. Because if we move to a publicly financed system, there's money coming from somewhere. Someone pays. And so we want to make sure that that is at a reasonable and sustainable rate.
But part of the vision of single payer, and I'm truly, obviously I've been a supporter of single payer, but I want to have a dialogue. Part of the cost savings is from what happens with the insurance industry, but part of the cost savings comes from the collective purchasing power of a single payer and how they negotiate with doctors and hospitals and pharma and other actors in the system. So how do you model that if you can't really model that in a separate cost containment effort that is not tied to single payer?
I think that's absolutely right. That as supporters of single payer, the part of it is the getting rid of the middlemen, the administrative bureaucracy, simplifying those types of issues. But still, even if you do that, you're still, like, again, 80% of our costs are doctors, hospitals, drug companies, plus probably anywhere from 80 to 90%. And so the question is this unit price issue. And again, I think the way that this country has tried is through competition, but there's and the three ways that you try to deal with this is competition, negotiation, or regulation. The competition has not worked particularly well because at the end of the day, consumers, purchasers, whether they be business or labor, don't have the ability to say no, right? If you need health care, you're just not in you're not in a space to do that.
It's a classic moral hazard.
Right, exactly. And it is not, and it's also such a consolidated field that there are at best market failures. So then the question is, what other mechanism do you use to have some oversight and review over prices, and and whether it's in a single, now in other countries, whether it's a single payer system or a multi-payer system, they use either the purchasing power of the government or the regulatory power of the government to provide that oversight. And so then the question is, can we build that mechanism even absent some of the other components as a stepping stone, as like the infrastructure that you would need for an overall single payer system, if that's where this legislature or future legislators decide to go. And it's something that frankly needs to be fleshed out in the 562 proposal that's there. As we support 562, we put it on our scorecard, but it is one of the questions that we had was that it builds this great purchasing pool of 40 million Californians, but there's not necessarily spelled out the exact mechanism of how it would negotiate with the drug companies if you don't necessarily have a formulary. And I know there was some discussion in the earlier panel about is that envisioned or not, or it's not spelled out. Again, the sponsors are clear that they did not go into a certain level of detail, but then that's where the details are about how do you negotiate. Do the drug companies get to decide if you're setting up a single payer system and saying you're covering every drug? Then the drug companies will then say, fine, we'll charge whatever we want, unless you have some sort of mechanism. And it doesn't have to be formularies, but then the question is, what is it, to then be able to make that negotiating power happen? And so you need to create a mechanism one way or another. We're suggesting that we should move forward with that project post-haste, because we're going to need it regardless of what we do.
Mm-hmm. Okay. One final question. What do you all think about trying to bring back an individual mandate to California? I noticed that was not mentioned in any of the proposals so far. I'm just.
Well, I'm actually, I think
I think you did. Yeah, you did allude to it.
I mean, absolutely. I think we've seen that markets are most stable and costs spread out are minimized. Cost increases are minimized the most when you have more people in the system. So whatever legal way it can be done to ensure that you're getting everyone in the system. And we all know a mandate and a penalty doesn't ensure everybody is in the system, even those who are eligible. But, you know, there's no, it's an additional tool in the arsenal. And obviously we need to wait to see what's going to happen nationwide with the mandate being pulled back. But absolutely, to the extent that that requirement can be in place and can have some impact on people joining the system, particularly younger and healthier people, we think that helps bring down costs and stabilize markets.
And health access and
I would, as I said in my presentation, and happy to repeat, we think that the number one driver of enrollment has been the subsidies, not the penalty. That has been what has been encouraging people to get signed. It's the carrots, not the sticks. And so we do think that to stabilize the market so that we don't have the impacts of the repeal of the mandate, which the CBO scored at 8 to 10% increase in premiums, which UC Berkeley estimated would leave about 1.7 million Californians losing coverage, and the impacts of that, including folks who may decide not to sign up for Medi-Cal or other programs as a result, that having an affordability package that encourages people to enroll, if it is in part funded by a contribution by individuals who are not paying into the system, that would be appropriate. We think that California could and should design one that's maybe more progressive than what was the federal government proposed. We also think that the mechanism of having just the prompt at tax time is just a helpful encouragement to remind people to get covered so they are not in a situation where they find themselves as the Covered California commercial had, on the roof putting up their Christmas lights and having a moment at the ER. It's a useful nudge to get folks there, but I think the primary focus should be on affordability, and that's what we were trying to lay out.
Great. Just one final comment, which is I very much appreciate your presentations, and I've had meetings, I think, with almost all of you and your organizations to talk through options. I think for us, we're all still looking for that next level of specificity around proposals. And I know there have been a lot of shots taken at 562 for some levels of unspecificity, but I would say on the other hand, we're also just waiting for other ideas, and if in the absence of ideas, we have something here that we're considering. And I would also note that I know that all of you had wanted to participate in today's panel, but it's very noticeable that there are many players that have not offered proposals. And I say this with greatest respect as a son of a doctor to the doctors, to hospitals, to insurers, to pharma. There are so many other players in this, and we need everyone to either give us your best ideas or help us figure this out, because we have to do something. So I just wanted to say that, and again, thank you for your presentations.
Just questions at this point. Yeah. So, Ms. Waldron, any questions?
Thank you, Mr. Chair. Lots of good discussion, especially about the formularies, because that was one of the questions I had. Will the issue of accessing treatment, which is always that comes up against the formulary, remain a problem ongoing if we move to another system? Reasoning because, I believe the doctor should actually have the say in what treatment the patient should get, but that's kind of unheard of in the current system. And will it be unheard of in a new system? I mean, how do you envision it? Because cost control is an issue, but, I've always advocated that if you can get the best treatments up front, you actually can save money in the long run, including hospitalization rates, just, community viral load if it's an issue of infectious disease, quality of life for the patient. They can actually maybe go back to work, not have to have a transplant or something like that. I mean, where will this new system fall? And maybe, as Mr. Chu was saying, we need specificity, because when it comes down to brass tacks, that's how we're going to make our decisions. If we just have the same kind of system we have now, then we still have the problem with access.
I would say that I think in terms of, I think there's always a balance between how do you make sure that you have the broadest amount of access to care that is, and we have, my organization is, the name of our organization is Health Access. We fought for for the HMO Patients Bill of Rights over a decade ago to make sure that people are not denied medically necessary care. That data about the independent medical review earlier was the result of some of the work that we had done and continue to do to make sure that people are not denied for medically necessary care. That there was an independent medical review process so that people, that those insurance companies are overturned when they are denying that care. Not to say that the problem is entirely solved, but that was an important first step for people to get the justice they need and the care that they need. I think in terms of, and whether it is with regard to networks, whether it's regard to formularies, I think that's always the balance. I do think there is always a balance between that and in the realm of cost control, because we also, as a consumer advocate, I also think it is appropriate to have a mechanism to be able to bargain for the best price and for the best quality. That if there is a provider or a hospital or whatever that is providing particularly poor quality, that there is or low quality, high cost care, that there is a mechanism to steer patients away from that, because that's not in anybody's interest, including the patients, if there is that case. And so I think that there is a role for those mechanisms, and that's something that needs to be fleshed out. It shouldn't be driven by profit. It shouldn't be driven by the needs of insurers behind closed doors. It should be in public and open processes, and that's one of the reasons why we would like a well-designed single-payer system that addresses that issue. But and I think that that's something that we need to be mindful as we take steps forward, cost control. But we don't, at the end of the day, we don't think that the issue of cost should have an impact on quality or access. Again, it's this unit. It's not because we use too much health care, and it's because of the price. And so the more we address just why that unit price is so high and why it goes up at an unsustainable rate, that's the issue that we have to get to, and that we should get to immediately, and we can move forward with that, even despite some of the other obstacles that exist.
Okay. We were talking about Maryland a little bit, and I pulled my notes from the previous hearings when we had Maryland, and the cost control was the topic. And, I fully agree. Anything that we move forward with, we have to get the handle on the cost before we just carry the baggage, with us to any other system. One of the things Maryland did, and I'm trying to read through my own notes here, was they combine, when they look at price, they look at utilization also. So they're kind of controlling on both ends. And I'm a little concerned on part of it, because they said instead of increase, like how it is currently, the more people that come in, the more money that's made, because you have more people going through the system, more people paying. But so instead of increasing utilization rates to make more money, the program will simply increase their budget by rate of growth every year. They used an example of, say, 2%. If they have so many more people, let's increase it by this amount. So it doesn't matter how many people are seen. So it's not based on the utilization. It's just money capped. And it's an effort to reduce hospitalization mistakes, they're saying, readmissions, infection spread, et cetera, because the budget's capped. But my concern is then people aren't getting care, because you can only squeeze so many people in on the budget. And one of the things they talked about was if a system is actually exceeding and they have better outcomes and mortality rates are lower and, people are getting healed, they don't have the infection rates, there's a bonus added as an incentive. And then the other side of the coin is if mortality rates are high or they're not taking care of people or they have more hospital readmissions, would there be cuts or fines to incentivize staying within the cap? I'm just throwing that out there because that is, we're talking about Maryland and costs and things like that.
Sure. I am not an expert on Maryland. I almost feel like the next hearing should maybe be in Maryland. But my understanding of why Maryland had a kind of 2.0 system, why they wanted to add the budget cap, was that it was kind of going back to the balloon analogy that I used. They were just looking, their system was all payer rate setting, but it was only looking at hospitals and only looking at prices. And so they were squeezing on prices in hospitals. And then over time, since the 70s, there had been a couple just shifts in the market. There was more care moving to outpatient settings that didn't have any price controls on it. And Maryland had an overall increase, as I understand it, in healthcare spending because there was so much utilization. They had really high rates of readmissions and hospital-acquired infections. So there wasn't maybe the quality that should have been out there. And even if you have very high utilization, but poor quality, you're not going to have great health outcomes. And so I think what they were trying to do was a little bit of what sometimes advocates call the triple or the quadruple aim, is that not only are you containing costs in terms of prices and utilization, but you also have to make sure that you're improving quality and outcomes for patients. And sometimes improving outcomes for patients means decreasing utilization because you don't want overdiagnosis or inappropriate care. And sometimes it means increasing utilization because you want to make sure you have those patients with chronic diseases that are getting the preventive care that they need, that they're getting their diabetes medication, that they're not showing up at the ER for these very expensive treatments. So it's, as the chairs and all the members of this committee know, it's a very kind of complex, delicate balance. And I think that Maryland's 2.0 was trying to get at that. And I'm definitely not an expert, and I don't think we've totally seen the results. I'd love to see more of kind of what came out of their experiment.
Thank you. So you know about Maryland. Okay, just a couple more things because I feel I need to say some things on the record. So we're touting, how many more people we've enrolled with Cover California, and it's far exceeding the national average of getting people into coverage. When you combine the Medi-Cal, Medicare, Cover California, the individual, the commercial, we're at about 92.4% of the folks are covered, as we know, and then we have about 3 million, underinsured or not insured at all. And we've kind of identified, I think all of our committees have identified some of the problems that keep rising up to the surface, which is the unnecessary services, the non-insured, the denials, underinsured, bureaucracy, malpractice, the streamlining, cost containment, improvements needed, access, always access. Why, it's just an open question. Why would we discard what we've done, which is 92.4% coverage, rather than focus on solving some of the key problems that we know maybe we could get a handle on if we did that, rather than starting a whole new system, trying to go and get these waivers with an administration that is clearly not going to be favorable to California, that could take years, that maybe leave folks kind of needing care and not getting it. It's just an open question. Is that not doable?
Assemblyman, I would agree that the first thing we need to do is fix what we can fix and shore up the ACA. That we've made tremendous gains with the ACA. I also agree with Anthony that a robust and functioning system based upon the ACA is going to be that much closer to a more comprehensive universal system. I don't think by working on that we're moving away from a long-term solution. I mean, as somebody who represents small business owners, it is a crazy quilt system. And well, first of all, small business owners have to take the time to figure out, to learn about it. Well, am I going to offer? Am I not going to offer? Now, if they don't offer, then their employees, have the choice of going to the individual exchange, or maybe they're eligible for Medi-Cal. I mean, that doesn't mean we shouldn't promote all of that, because those are all options that didn't exist before. But I do think that by doing that, we do our best to solve those problems, and then we also put ourselves in a position to simultaneously, work on potential long-term solutions which do have financial and legal consequences that aren't going to be fixed immediately. So I don't think it's one versus the other.
And I would agree. I don't think it's the dialectic of ACA versus a completely different system. I believe that these are all within a spectrum, and that the ACA did get us closer to in a lot of different ways, and expanding, just getting more people into the health system, and expanding publicly financed coverage, in providing those providing additional just resources that could be, if it all works together, put for as a down payment to the financing of a broader healthcare system, for defining what the term coverage is and what are essential benefits, and setting a standard for that, putting limits and maximums for co-payments and deductibles, even if we think that they're too high, that at least put some definitions and structures in place that then we can adjust going forward. I think if we can take additional steps with regard to cost, with regard to addressing some of the issues that are outstanding, in whether it's the issue of should all Californians be included regardless of immigration status, as Betsy was talking about, or whether it's the issue, if we can address that issue, that's one less issue than we have to deal with the next step in reforming our healthcare system. If we can deal with the issue of additional getting more people in coverage, that's just that means that just narrows the further gap. So we certainly don't believe that this is an either or. This is a continuum, and we're along this continuum, and we appreciate that there are some people on the dais that may have different desires of where you want to end up on that continuum, and so we hope that an agenda on cost containment is something like the work that we did last year on prescription drugs, is something that attracts interest from both sides of the aisle, even if you don't buy into the fact that is takes us all the way to a single payer system. I think that we can have some agreement on the next couple of steps, even if even if you don't buy into where it all is, because again, I don't believe it's a slippery slope. And you may decide that the view is okay at X level of the mountain, where others want to keep climbing to the top.
Well, thank you. That's an excellent point, because I think at the end of the day, we all want to have access for the patient. The patient is the one that sometimes slips through the cracks. So I'm going to combine like 4 questions into one, just for the sake of time. And this is one no one's going to like, but I just need to say it. We looked at Vermont 3 years ago. They had to withdraw from their single payer, plan that was signed into law. They had a bill they signed into law in 2011. Because the income and payroll taxes had to go up so much. Now, Vermont is a lot smaller than California, so that could have been part of the issue there. Colorado voters rejected a single-payer plan in 2016, 80-20 ratio. The Democratic governor had to urge his voters not to support the bill because it would double the state budget. Then we did have a lot of hearings. We looked at other states, what they're doing. We looked at other countries, which was actually fascinating and very informative. and we saw the scale of how much we're paying and how much less we get versus other countries. And when you looked at, and that's why I brought up about the network of social services and all the other things that are being done, how the ones that seemed to work the best actually had more payer options. They actually had private plans mixed in with the government plans. Those seem to be the ones that were really the strongest. And, you know, I've done a lot of study on it and came up with, there was a study that's been done, this entity over 2 decades, 12 specialties, 12 provinces in Canada, and it looks at wait times. It's a big study. This is the one from 2017. And it's showing that from getting to a primary care doctor, being referred for treatment to a specialist, the average is 21.2 weeks of wait. That's over 5 months in Canada. To go from a general practitioner to treatment at a specialist for ophthalmology, almost 8 months. And it is done by the Fraser Institute, 2017, and it's all here. I'm pointing this out, so maybe if there's data to prove it's not right, we want to hear it. Orthopedic surgery, over 10-month wait. And as I said before, my relatives come from Canada. They bought supplemental plans because they, had more money, and they're able to do it, which once again, we have the underserved community will not be able to buy a supplemental plan. So how will we ensure that this doesn't happen? And, as we move forward, that's why I want to bring it up. I don't want to go down the path. How can we ensure that it won't happen in California? What can be done? Because if we don't have enough providers as it is now, people are paying for the plan through their taxes. They buy, something, the sales tax will pay for it. So they're not actually paying when they get there. It's considered free. They think it's free, so they're going to use it more. They'll be going to the emergency room more. And that's what they've seen in all these places. And that's what causes the wait time issue. How do we prevent that? It's an honest question, and that's my last question.
So I'm happy to provide evidence. I don't think we've ever seen anecdotally or evidence of Canadians coming to America for our healthcare system. If anything, it's the reverse. But we're happy to provide data to you. I don't think that there's a lot of people who go to the emergency room. There's no binge shopping going on in the emergency room. People, if people go, they need to go care. It's nobody's idea of a good time to go to the ER. Are there mechanisms to try to encourage people to go to primary care rather than emergency rooms? Absolutely. And we think the key thing is to provide those urgent care and primary care and other options so that people can, get the care that they need in the appropriate place rather than use the ER appropriately. But I don't think anybody desires to do that, and there are existing systems in place for the quote unquote frequent flyers of people who do show up occasionally for specific issues, but those tend to be issues more about our social safety net and about do we have appropriate housing and homelessness and other types of services in place. I think the data actually shows that in fact there's a lot of us, one of the reasons why we have a very high healthcare cost in America is because we actually have relatively low investment in the social safety net, and so it's reflected in our healthcare system as a result. And I think that maybe goes to this other question of with regard to the in terms of Canada. I mean, at the end of the day, California will create its own healthcare system that will be different than Canada, that will be different, it will be a California healthcare system, and we can put in place the consumer protections about wait times, et cetera. We're trying to do some of that with our existing system, with standards with regard to timely access to care and other pieces, and we think that that should be incorporated in whatever system we move forward with. That was one of our questions about 562 as well, is just making sure that the standards that we are trying to hold the insurers accountable to in our current law, which sometimes they don't abide by and they get fined for, are in place for whatever our system is, and so I think that but that will be a decision based on at least a process that is determined by democratically elected representatives rather than by insurers in a private boardroom.
Thank you. I want to start my comments today, if I can, by remembering where we cut our teeth and how we learned to become advocates. I was moved by the California Immigrant Policy Center, which started in 1996 after, I believe, the 1994 Prop 187. And I also have been fighting for health for all, and really believe that that goal is a noble one, and want to focus, if I can, on three main areas. First, I'd like better information, if I can, from the small business owners as well as Health Access regarding the family glitch. How could we better meet the needs of our families, and what could we do to improve upon that? Second, I wanted to ask about the medical loss ratios that was brought up, both in terms of stabilizing and opportunities for us to look at increases, and if you could further extrapolate what raising this amount would do for us as Californians and how that would help us. And finally, I'd like to ask about the underinsured. That's an area that really touches home to me. When you brought up the fact that $12 an hour is going towards health care, I'm reminded that there are many people in my district who don't make $12 an hour and want to figure out what we could do as a state to help in paying for those premiums and cost sharings, what opportunities we had to help the middle class within our state to realize the successes.
I'll take a couple of these, not all of them. So the family glitch, I mean, and as I said, that particularly hurts small businesses that tend to have plans that are employee only, when they do have plans that are more often employee only than larger organizations and businesses that have plans that often include dependents. I'm not sure, I would defer to experts here, I'm not sure that, in other words, I think that we can't increase the federal subsidies on our own, to cover dependents of who are related to employees that have plans where they meet the affordability standard. So I think it would require funding. I mean, let's be clear. And that's a decision all of you need to make with the surplus that exists of, there's a million places where that money can go. It is a huge problem for employees of small businesses that have dependents where the businesses have struggled to offer the plans but still want to offer it but you can't afford to offer dependent coverage. So I wanted to point that out. As far as MLR is concerned, I mean, we just want to make sure that there's some standard in place. And there were two more proposals today in Washington for eviscerating this, that, or the other. So I just want to, I think I just wanted to point out that it's important that if there's a need to have a legal backstop in case Washington does some more crazy stuff, we should have that. I want to make one point on immigrants. As many of you know, immigrants are twice as likely as the general population to start and run small businesses. So when you talk about immigrants, and obviously it's both documented and undocumented, you talk about immigrants, there's a huge crossover with small business in many parts of this state. When you look at the small business community, it's predominantly immigrants. And so to promote and continue to promote entrepreneurship in this state, we have to deal with the medical needs of immigrants, both documented and undocumented.
Again, on agreeing with John on the family glitch, I think it is certainly a doable proposal. We have been modeling how much money would be raised, and I do think, depending on what else the federal government does, that actually might have some impacts on how much fixing these family glitches. This is something that we believe that a different president with a different IRS would have interpreted in a different way and would have solved this at the federal level. But again, given that we don't have that for the next 3 years, it would be appropriate to take a look for folks, again, individuals who get worker coverage for themselves, but not affordable coverage for their family members, and it's those family members that are, don't have the ability to get subsidies in the exchange as a result. Some of those folks buy coverage anyway; they just buy it at a much higher percentage of the of their income, and it's something that it would go a long way toward affordability. It's not a huge population. But it's a population that deserves some attention. In addition to some of the other affordability proposals that we outlined on the medical loss ratio, I do want to just highlight what this is, because it's a very technical term, but it literally is how the insurers describe how much money is "quote unquote" lost to actual medical care. It's the description of how much money is going to medical care. We think that should be higher, and just as public programs do, whether it be Medicare or Medi-Cal, both have much higher medical loss ratios than in the commercial market. Now, some of that is just the impact of having a system where you have to do marketing and hire people to help sell the product, and the transactional costs with relation to that. But some of that is about profit, and some of that is about administrative burden. And so, taking a look at how we can do that, and especially since we are doing more on the Covered California side of trying to have that centralized and get people into these plans, and does that mean that, hey, now we can ask the insurers to be more efficient, since Covered California is doing some of that work for them, and I think that would be appropriate.
So before we get to the other ones, I just want to make sure I understand that fully. By increasing the medical loss ratio, the premiums that Californians are paying, more of the percent of that premium will go towards direct health care related costs.
That's right.
So we will see a better benefit by increasing the medical loss ratio in terms of direct results as Californians.
That's right. Yeah, and I mean, currently the way the ACA works is that if they spend too much, if they violate the MLR standard, then actually individuals get rebates. And California, actually, hundreds of thousands of Californians have gotten rebates. They tended to be relatively small checks, but it is it's a useful prod to encourage the insurers to that if they are going to try to provide value for the consumer, the proof where the pudding is, where to say that they're going to spend 80, 85, or whatever the right percentage is for patient care. But we also think that then that does still circle back to, if 80 or 85% of the premium is doctors, hospitals, and drugs, then we still need a mechanism to addressing those base costs, and that's the kind of things that I think several of us have been talking about.
And just to finish, so I can pass it on, I was moved, Peter, when you said that this was a shared problem that we need to solve together. And you had mentioned employers and employees, but I'd like to make sure that we're putting the state of California in there as well. We are California, and we don't follow the rest of the states. We are leading on this issue and wants to make sure that we are doing our fair share to help our brothers and sisters who are working, who are struggling to make ends meet, who are the people in my community. And just really appreciate all of the work that this panel has done to bring these presentations here today.
Thank you. I think I'm going to more comments. I think some of the questions, the key questions, have been answered. Did you have some? Okay. More comments, and I think it's important. First of all, thank you very much for your work. Thank you for giving us your stories and the importance there. the takeaway, I guess, for me is that that as we move, we need to move on two tracks. We need to move on the track to a system that is different than what we have today. And what that looks like exactly in California, I don't know. But we also have to work on those things that we can work on now. And because if we don't contain costs, if we don't slow down and bend the curve, it's going to make it that much more difficult with a friendly administration to get to the top of the mountain. And so these are foundational things that absolutely have to be done. And so I'm anxious to see what it is that as we flesh this out, that we can actually be working on this year to get there. Because the other projects, we know, based on our hearing that we had Monday, some of the logistics and the challenges we have going forward are multi-year challenges. And we cannot ignore that. Waivers with the federal government with a friendly administration still take 2 to 3 years. We don't have a friendly administration now, but that doesn't mean we can't do the foundational work to get to where we need to go. So I thank you for that. Look forward to working with you on that. It is absolutely imperative that we slow this down. One of the beauties of Maryland, what they have done, slow the costs down. Sorry. Wow. Slow the cost curve down. And I want to, and the reason I'm saying that is that Maryland has done what Maryland has done is really admirable. It has bent the curve. It has slowed the costs down. It hasn't dropped them, but it's slowing the costs down. And we've got to do that because we cannot sustain the increases year after year after year. And so I thank you for what you're doing. I look forward to working with you as we look forward to working on a parallel track, but recognizing that we cannot ignore the work that we need to do now because it will make it that much harder for us to get, like I said, to the top of the mountain. So, other comments before we go to a public comment?
Yeah, I think I'll make comments now before the public comes up, if that's okay. So this is, I think, the last of our hearings.
The last scheduled one.
The last scheduled hearing. We may do more, it sounds like, which is fine. And I know there are people out there that, think that these hearings were, not necessary, but I can tell you from someone who, no matter what, is going to have to vote on something, I found them very important and very educational, and I hope that everybody did. I hope the public watched and learned something. I know that I learned a lot, and I think all of us from going through this process did. And, I think a lot of this discussion has to do with really changing impressions of what we think healthcare is. And the slogans that a lot of the activists used about healthcare being a human right might kind of sound obvious, but it's really not obvious. And it's certainly not been the way that healthcare has been regarded in this country. There was once a time, I'm sure, where, the way that people got healthcare was they were in their small town and there was a doctor or two, and if you got sick, you went to that doctor, but we've evolved. There was once a time in this country when if your house was on fire, there were different private fire companies that you could call that would kind of come, and you could pay them or not pay them. And if you didn't pay them, they wouldn't put your fire out. And at a certain point as a society, we decided that we had a public benefit towards there being public safety that we all paid for. And it's the same thing with public education. Nobody questions that all of us pay collectively into educating society's children, whether they're your child or somebody else's child. And I think that this is the result. When I say this, I mean this hearing and people being here is not just a result of costs going up and medical care being less and less expensive, but of an evolving perception about healthcare being something that we should all have. And if it's something that we all have equally and that everyone should expect, we really do need to change the way we think about paying for their healthcare. We don't expect everybody to pay individually for their children going to school. We all pay. We all pay, and nobody questions that because we know there's a public good for all of us of having educated children. And we have got to think about healthcare in the same way if we're ever going to have the kind of healthcare that we want and the kind of access we want. Because we've heard over and over from every single person who's been up here, from across the ideological scale, from people who have studied this issue, that the system that we've had, that's just been the system that's naturally evolved for 200 years, is one of just almost unbridled free market competition with private companies paying the bulk of healthcare costs for their employees at great cost to them, and with a market that's almost unregulated as compared to other developed nations. And so the single payer conversation is, it's important, but whether we're single payer or not, that's only part of the equation towards really having the kind of healthcare system that we need, because we have got to do the couple of things that other countries have done that we've been reluctant to do. Number one, to truly regulate the healthcare industry from beginning to end so that the costs are kept under control by government intervention. Every other developed country does it. And we do it in a lot of areas, in public safety and in education and in utilities, water and power. We don't have the unbridled free market at work. Our governments decide what's fair to pay for different parts of those services. We all get to see what that is. Everybody can look at their website for their local government to see what they pay for police and fire, to see how they negotiate those, to see what teachers are paid and what administrators are paid. We don't allow the free market to decide what administrators in the public school systems or in our local governments are paid, because we consider that to be too important to leave up to the free market. And we need to be willing to do that on all aspects of healthcare, which is extremely different than what we do now and very disruptive and very difficult to get to. Let's be honest. Last year we had a bill just for transparency in drug pricing, and that barely got through this legislature. So this is a huge task to do this all across the spectrum of healthcare, but it's the only way to really regulate costs. I found it really interesting that we had some folks from a very progressive doctors group come up, and thank you for being here to testify. And one of the things they said was, we need to do all this regulation, but let's not look at doctors' salaries. We have got to keep those salaries kind of where they are because we have a doctor shortage, and we don't want to interrupt that. Well, we have to look at everything. That all has to be on the table because that's the way it's done everywhere else. And if you have one group that can kind of charge what they want, then the next group's going to want to charge what they want, and the next group. So I'm saying this only to remind you what you already know, which is that this is a fundamentally different way of looking at healthcare than we've done it. But I think we really have to do it because the other thing that we know is that the current system just doesn't work. It just doesn't work. It doesn't contain costs. It doesn't deliver care well. And I do think that single payer is the goal because it seems to be the best way to utilize that ability for the government to control costs and negotiate. It's elegant. It's more simple. It's not the only way it's done in other places, but it seems to be the one that is the most effective. When we talk about cost containment too, we talk, when people mention waste and all of that, what we're really talking about is somebody's profits and someone's job. And those people are going to fight back. And there's a lot of them and they've got a lot of money. So all of us who want to do this have to realize that this is not going to be something easy or simple that's going to happen overnight. It's going to be a huge fight in every step of the way, as you all know. Sorry, I didn't write a speech. These are just notes. And there's a lot of them here. We do, I think, need a roadmap that builds on the goals of 562. It's a great statement of principles. It's a great statement of values, but fleshing this out into a comprehensive system is going to take time. And, that's something that I think that we need to really start doing, realizing that we do need that roadmap. We need it to be in place at the time when we have a federal government that's positioned to give us the waivers that we're going to need. And I absolutely agree that this is a roadmap that's achievable in steps. And there's a lot of things that we can do as we get there in covering all of our residents, whether they're documented or not, in making sure we have cost containment to give relief, to fill in the gaps where there's unaffordability right now for people in covered California, in all of those areas. So I hope that everyone who's been here is committed to working with us. I know the advocates are going to be here. Bless them, because, that's the energy that, we need to hold everybody accountable, us and the ones that are making money on this. And with that, I'm committed to having as many hearings as it takes to work on this. I'm committed to working as long as it takes with my colleagues to try to come up with something that really is a model for the rest of the country. I think everybody who didn't see it, everybody who didn't watch the other hearings, particularly the last hearing about the challenges that we have, need to watch that, because we all have to be mindful. There may very well be ballot measures that are necessary. We heard the legal experts say that's probably going to happen, and we can't ignore that. We don't want to be tied up in litigation for years trying to implement this either. So, this is one of the most exciting things I think that any of us can do while we're up here. I mean, if we walk out of here whenever having fundamentally changed healthcare delivery in California to make sure that it's affordable and accessible and excellent for everybody in the state, even if we don't do anything else, we can all retire happy legislators. So thanks, and we'll keep going.
What could one have to say after that? No, again, as always, it's, this has been a great education process, and I do probably think we will continue it. I think the Assembly member said it perfectly. If we do nothing else, if we are able to accomplish and we are able to provide all Californians health care and in turn create a model for the rest of the country, I think we have all well done more than we ever had hoped for when we ran for office. So so ditto everything she said.
With that, we are going to start public comment. And just as we started the meeting here today, just wanted to thank again the panel for being here. Really appreciate all of the testimony. So,